Okay, we're gonna get started. Paige, if you could grab this and get them to fix it. Once we start taking questions, we're gonna have this out in the audience so we can hear you guys, because it's a very big room. So we thank you guys for coming. My name's Randy Carver. Joining me is Kathy Carvin to my right, and to my far right's Dr. Rich Berry from Maple Health. Appreciate you guys sharing some of your time with us on this really important topic. I also want to thank Townhall from MFS, Brendan from Fidelity, Dustin from Jackson, and Brandon Lindley from Eden Vance, who helped sponsor the event this evening. So in 1990, we founded Carver Financial Services with the vision of making people's lives better. And these types of community events are part of that mission. One of the things I think in life in general, and specifically with our health and with investing, is we can't necessarily control, what's going to happen to us. But we can certainly be proactive in our approach. But one of the things is having really good partners. And of course, for a partner to be effective, you have to have access to them. And that's true with any professional partnership. Now, it's been interesting because in the last decade, in the last 20 years, there have been a lot of advances in medical technology, medical care, producing better outcomes with a lot of things. But at the same time, we're seeing life expectancies decrease in the United States. We're still seeing a lot of problems with chronic illnesses like obesity, diabetes, those types of things. And I think, obviously, timely care is probably more important than ever. Getting to see somebody in a reasonable amount of time is important, and it's becoming more and more difficult. Whichever big system you happen to be in, there's long wait times, limited availability, especially getting to see a specialist could take weeks or months, let alone a primary care doctor. So for some, these delays can really negatively impact outcomes and impact health. So tonight, what we want to talk about, one is some different or alternative ways to access healthcare, and then also talk about the insurance side, specifically with Medicare and other types of insurance that may be available, and how that's integrated, and how to look at it. So we're going to discuss that. We're going to have some questions to Kathy and Rich, and then we're going to open up to all you guys. Hopefully, we address a lot of the questions on the front end with that. Now, as some of you know, in 2013, we started an initiative called Carver Cares. And the idea is to make people aware of local nonprofits, what their missions were and what they were doing. We're fortunate to have a lot of really good organizations in Lake County that can help all of us. And a lot of times people just aren't even aware that they're out there. So this, I think everyone would agree, is a pretty contentious time. Whether it's presidential debates or school board meetings or whatever it is, it seems like people really are not communicating well. And I think it's important to understand more about how we can disagree, perhaps more civilly, or at least have discussions about more divisive topics that are constructive as we go forward. And I think as individuals and as a country, we're not very skilled at that. It's not something we focus on. And that's what tonight's Carver Cares Partner is working on. The group is called Fighting to Understand. There's some flyers out front that get into it, but they've basically been working for about 7 years now on how can you have constructive disagreement, and how can you tap in to a collective discussion among a lot of people in a productive way. And so, again, everything from the debate to the school board meetings, homeowners association meetings, it's very difficult sometimes to even address these types of topics. So they've been researching ways to improve how we disagree. They've got some new tools that can be deployed for various groups. It's kind of interesting if you're involved with a board or homeowners association. And really what they've done is combine 70 years of research and now using AI to try to collectively have people have these discussions. So I think it's pretty timely. They're now working on something called interactive brainstorming, which is really interesting. And if you have any interest, as I say, we have some flyers out front, and I'd encourage you to check it out. So, as I say, it's been interesting because in the last 20 years, healthcare, in a lot of respects, has improved, but I think in a lot of respects, it's gotten much worse as far as accessing the system, doctors having time to see anybody, just pushing people through, as far as that goes. And that's really what we want to talk about tonight, as far as how can we have better access, how can we have more affordable healthcare that's more personalized to each of us. So, with that, one of the things I think people are hearing more about is concierge medicine. As some of you know, we spend time in Florida, and honestly in Florida, unless you have a concierge doctor, it could be 6 months to get in to see somebody, let alone a specialist, which could be 9 months to a year. And so most people are familiar with traditional insurance-based medicine, and then some people have heard of concierge medicine, but there's a third alternative called direct primary care. And so, Rich, maybe you could let them know what the differences are between the different types of care.
Hey, good evening. Thank you everyone for coming tonight and having me. That's a good question to start with. Obviously, direct primary care is a pretty new concept in this area. It's been around in general for about 15 years, but that's been more kind of the metropolitan cities. We haven't really seen it reaching places like Lake County. Everyone's heard the term concierge. Basically what that means is someone pays an annual fee to be able to access their doctor when they need them. So for example, someone might pay $3,000 on the 1st of January. That doesn't actually buy them any care. That just gets them into the doctor when they need them. But then when you see that doctor, that doctor will then bill your insurance for any services that are given. So you need enough money to pay the membership, and then you need good enough insurance to be able to pay for the care that you need. With direct primary care, it's a monthly membership that is completely separate from insurance. So you pay that monthly membership, which is much cheaper than the concierge premium. But then when you come to see us for visits, you're not paying co-pays, you're not paying deductibles, there's nothing out of pocket. And any things that we can actually do ourselves would be included in that. So things like sutures, joint injections, skin tag removals, EKGs. So that monthly membership actually buys you some care, or all of your care, unlike the concierge fee.
Okay, cool. So Kathy, maybe let's talk about insurance, because with the direct primary care, you're paying the fee, but you're getting some care, but obviously you still need insurance. A lot of people here may have Medicare, but maybe talk about a little bit some of the changes, eligibility, where it makes sense, and just kind of a high-level overview.
Yeah, Medicare you can get when you're 65 or if you have certain disabilities, and it's something you earn because you lived in the United States for at least 5 years and you paid into it. The way you qualify is you just apply for it, and there's Part B pays for 80% and you pay for the 20%. With Medicare in general, you can choose between getting a Medicare Advantage plan or a Medicare supplement, and that would be like an extra fee, and that would pick up the extra 20% and the deductibles.
Okay, cool. So, what typically are the out-of-pocket costs associated with Medicare versus traditional insurance?
Okay, original Medicare, you're going to have co-pays and co-insurance, and you're going to have deductibles. So what a Medicare supplement does is it picks up the deductibles and the co-insurance, but you're just paying a monthly premium on top of that, on top of your Part B premium. Regular insurance, when you're under 65, those insurance plans have very high deductibles now, because now everyone is covered, all pre-existing conditions are covered. So the way we've been watching it is that in health insurance, the premiums have gone up and so have the deductibles. So unfortunately, we're in a circle that is not, not favorable.
Cool. So Rich, like I said, I think how many people here have had an issue getting in to see their primary care doctor in a reasonable amount of time? Or especially if your doctor retires, new doctor comes in and they say, well, to do the first visit, yeah, I mean, it takes a long time. So, I mean, again, it seems to take weeks or months. How does direct primary care a little bit different?
Okay, so in this area, over the last few years, we've seen a huge amount of doctors retire. I don't know the exact numbers, but I imagine it's probably a good 20%. Those doctors left are looking after between 2,000 and 3,000 patients each. With direct primary care, we actually have a cap on the number of patients that each doctor can see. So in our clinic, we don't allow anyone to see more than 600 patients. That means we can do 1-hour visits. We're always available on the same day, and you always get to see the same person. For patients that are members of our clinic and are patients with us, for acute issues, we have same-day access. If somebody was to call us and want to join the clinic and become a patient of ours, we get them in between 2 to 3 days would be the absolute max. The average wait time for a new doctor at the other health systems, you're probably looking in excess of 3 months. I mean, for some of them, up to 7 or 8 months.
So it sounds like a lot of stuff, I said EKGs, lab work, basic sutures, that kind of stuff you guys do. What if someone has to see a specialist? How does that work with the direct primary care?
So with the direct primary care model, we can refer out to specialists in exactly the same way as any hospital doctors can do. Obviously, the monthly membership that we charge doesn't cover that visit. The vast majority of our patients do have background insurance that would cover cardiology, mammogram, colonoscopies, hospitalizations, surgeries, and all of those things. But we're able to get people to where they need to go. We do have a high amount of patients with very high deductibles or uninsured, in which case we have certain specialists that we refer to that we know work well on a cash pay basis if that's necessary.
So, obviously if you have insurance, people have a deductible. If they come in and they do lab work or they do a typical visit, how much is that? You know, how much does it cost them out of pocket just to come in for whether it's a well check or hey, you know, I'm sick, I need you to look at me.
So the visits themselves are actually included in the monthly membership. So if you came in for an annual physical, sick visit, injury, management of blood pressure, diabetes, those visits are no additional charge. So you're not paying co-pays or anything like that. The only thing, I think we lost it. Oh, no, got it back. The only additional charges that we have in our clinic would be lab work. So if we take a regular annual physical checkup, that blood work, if you had it done at a health system and didn't have insurance and were paying for it, you might pay $300 to $500 for that. If you do have insurance, there's still going to be a co-pay to charge. We do everything in-house, and the full annual physical labs would be $17 through us. So even those people who have very good insurance still get all of their blood work through us because it's still cheaper than the co-pay. Then we also have our own pharmacy on site. So we can order people's regular medications for long-term prescribing. We have all of the acute antibiotics, steroids, muscle relaxers, anything that we'd need. They are an additional charge, but it works out doing it through our pharmacy about 80% cheaper than going through a standard pharmacy.
Cool. Okay, so, we talked a little about this, we talked about the insurance briefly. So Kathy, what are some of the recent changes made and what can we expect, coming up, both for the patients and also for the beneficiaries, generally with insurance?
Okay, so Medicare is actually going to have some changes to their drug plans. The maximum out of pocket for the drug plans are $2,000. And if you're taking expensive medications and you're going to hit your catastrophic fates within a couple months, you're allowed to spread out your prescription drug plan costs throughout the year. So that's a big change. And then also, all the diabetes drugs are going to be $35 or less as long as they're in the network. And for the under 65, they're looking at the premiums going up like an average of 7%, unfortunately. But they do cover all wellness visits, and that's the labs, and they did add prescriptions, zero cost prescriptions.
So,
Okay. What mistakes you seeing people make, both under 65 when they're looking for insurance, if they're not covered, and then also over 65, because they say, what are some of the common things, missteps people should avoid?
The biggest misstep is when they ask their friends what they have, and their friends are probably taking different prescriptions or have different doctors. It's always good to consult with someone who's unbiased and can look at all the plans. The big mistake for under 65 is that when they move from group insurance, they're used to PPO plans and not paying that much. Now they're going into HMOs, and you have to stay in one hospital system. Those prices are a lot more expensive, but if you do make less than $100,000 a year, you could qualify for a subsidy.
Okay. So Rich, I had a MRI done, and nobody really told me how much it was going to be till afterwards. They just don't. Is there any way to know, kind of go in and say, this is how much this is going to be, or that's going to be, versus the surprise?
Yeah, that's a big problem with a lot of services. It's not just unique to MRIs. It can be visits, it can be MRIs, it can be meds. People get that service, they get the image done, and then they get this bill and they can't do anything about it because it's already been done. So what we do is we partner with some local imaging centres. These imaging centres offer cash pay imaging. So they also bill insurances. So let's say, for example, if we were going to get an MRI of somebody's neck and we sent them to one of the big health systems, we could be looking at a $3,000 bill for that. If we were to use the local imaging, we know what the cash pay is. So there's a place in Mena that we use, and I know I can get an MRI of the neck paid cash for about $700, give or take. So we use those services. They still will try and run it through insurance. So if they can get it covered by your insurance and you pay a copay of basically a smaller amount, that goes through. But that cash pay is going to be $700 at the most. We can do the same for CTs. We can do the same for ultrasounds, x-rays. If you got, let's say, an x-ray of your foot, I know this one by experience personally. I had an x-ray done of my foot through a health system, and it cost about $800, whereas we could get that done locally cash pay for about $135. So that way we know exactly what the maximum is going to be, and if your insurance kicks in, we can get it even less.
How does it work with people on Medicare? Is that a consideration, versus call it the traditional insurance-based medicine? Is there any consideration if people are on Medicare?
Probably about 30% of our population are actually Medicare patients. 10 years ago, I think Medicare would have covered services elsewhere. 10 years ago, doctors were available, insurance wasn't too expensive, things were covered. But the problem we have now is even if you have the best insurance in the world, it doesn't buy you care. It doesn't make those doctors available. It doesn't mean you can get into them. So with our Medicare population, we have quite a few people who, when they need their doctor in good time. So people are happy to pay that monthly membership to come to see us just so that they can get the care when they need it. So Medicare really isn't a barrier to using direct primary care.
Okay. I think one of the other things that comes up, and both UH and Cleveland Clinic use MyChart now. You can't really call someone to get an answer. They want you to MyChart them. They have 72 hours to get back, if they get back to you. Obviously with the practices, and not just, we're using your practice, but direct primary care is all over the country as other medicine. How does it work? If someone just has a question, something like that, how easy is it to communicate and get answers back from somebody?
Okay. Because we keep our numbers low, we can actually keep our own call. So most other systems, you might have 10 doctors looking after 2,000 each, and you'll have a doctor on call each night to take all the calls. For us, we take all of our own phone calls. So for our patients, if it's something they just got a question, they want a med refill, there's a question about a prescription, people can just text us, and that's 24 hours a day. We're also available by phone call 24 hours a day. We just say to people out of business hours, keep it to those urgent things that really need us. But for our patients, if we had someone who woke up in 2 o'clock in the morning with chest pain, something like that, and they're wondering whether they need to go to the emergency room at that time or whether they can wait to see us the next morning, they can call us at 2 o'clock in the morning. It doesn't go to a nurse line. It doesn't go to an on-call person. They will get through to their doctor at that time. People have been very sensible with that. In the 2 years the clinic's been opened, I've probably had 3 phone calls in the middle of the night, and I think 2 of them I ended up having to send to the hospital. So the system does work really well.
Yeah, sorry about calling you.
I can add to that about the so what I've also been seeing is for the under 65, most of the insurance companies are having online telehealth, so you can call them right away via your phone or an app, and you get a doctor within 10 minutes. They're all going remotely like that because they know how hard it is to get in to see your doctor. And because Cleveland Clinic is all MyChart and University Hospital is the same, it's a lot easier to make appointments through the tele-app.
All right, so are there any other, before we open it up to questions, are there any other thoughts that you have kind of with regard to the insurance side?
I think the insurance companies know how hard it is to get hold of a doctor, because you're right, a lot of doctors retired this year and the past 5 years because of all these changes. So they're, even though all the plans are HMOs when you're under 65, they do have the tele-app, so you can always get a hold of your doctors. You can get your prescription sent to the pharmacies right away. But they're trying to make it as easy as possible. They understand the problems we're all facing.
Okay. Rich, any other thoughts before we kind of open it up to questions?
Yeah, so in healthcare in general, I mean, obviously cost of healthcare is a huge issue. More importantly, probably the access is the biggest thing. Obviously with the insurance companies that are doing some work with the telehealth, obviously we're getting that level out there. But we kind of just need to turn the clock back a few years where we just kind of have that availability when we need it, and when we get it, we know it's not going to cost a fortune. So kind of with Maple Health, that's what we're trying to do. Like we're staying local, we're staying small, just so we can kind of keep that access and quality moving forward, no matter how many doctors we add to the system.
Okay, we're going to open it up, and I'm going to ask, I know where Paige is. She's going to bring you the microphone because it's going to be really hard to hear the questions. I'm unless you speak. So if we have any questions out there, here's one, Bob Weinberg on the...
Is direct primary in addition to night care, or is this an offerings on service and that covers it?
You have to map it off now.
Legends from the doctors that are participating.
Yeah. So,
All right. So yes, it is in addition to, because when we think about direct primary care, we take care of all of the primary care needs. So chronic care, diabetes, things like that, high blood pressure, injuries, sick visits, annual physicals. But if someone ends up needing an open heart bypass, if God forbid someone ends up with a cancer or trauma, something like that, obviously the Medicare kicks in to cover all of those hospital bills. And then you also said about the number of doctors in this area. There's very few. We're the only direct primary care clinic in Lake County, and there's myself working there and Courtney, who's all the way up the back there. So there's us two. We're going to be adding a third person in March. In the area, there's another clinic there's one in Beechwood, there's one in Hudson, there's a couple on the west side, but we're actually the only ones in Lake County at the moment.
This is what doctors are doing. I know you mentioned a down payment when you first into your eye with no locally. So I need to determine what the down payment is.
yeah.
There's no down payment. Basically, it's works on a monthly membership. So we break it down by age groups. So we have under 21s, 21 through 64, 65 and above. If someone wants to come to see me, the under 21s are $80 a month. 21 through 64 is $100 a month. Above 65 and up is $110 a month. Courtney joined me last year. We're trying to grow her numbers. If people were to see her, then it's 60, 70 or 80. But then that monthly membership, as we said, includes any visits you come to us. So you're not paying co-pays when you walk in the door. You're not paying any extra for the visit. If you have a rough month and need us 3 times, you come and see us 3 times. There's no additional charges.
This is about your cage, just like things. The first one is, your building is not reason, I guess, that you couldn't, if you're able to say on like they have an IRAD curve to listen to her, if your building's not a reason, if they have both your services as well, right?
I'm sorry, if I just make sure I heard the question right. You're saying why add our services on top of Medicare?
No, he wants to keep his doctor.
Oh, you want to keep...
Supplement, that his doctor.
Okay.
So you'd have 2 primary care centers.
Yeah, I mean, it doesn't particularly work very well to keep Medicare doctor and have us. Because at the end of the day, when you need us, you'll get in quickly and everything's dealt with. And also as well, when you've got healthcare, there's lots of correct ways to do the same thing. So if you have multiple doctors managing blood pressure, diabetes, even though both doctors might be correct, they might be slightly different. Then you end up with med interactions. The doctors don't really know what's going on. A couple of people have come to us with that thought in mind, but when they realize how quickly they can get in, how long the appointments are, and that everything's addressed with no hassle, people generally move all of their care to us pretty quickly.
Yeah, turn that off. Yeah. Hang on, we'll get it. Okay.
Where in Lake County are you located?
Yeah, hang on. They're right by my office. They're about 500 yards north, across from yours truly. They are moving though. Locally.
Okay, so I'm new with the doctor, and the black person will be doctor. I cross over. So if I am on,
This is off.
if I am in Florida, or if I'm overseas, and something happens, you think I can call 24/7. But do I get to do a telecall with you if something goes wrong, or how would that work?
Yes, so that's actually one of the benefits of the clinic. So we can do telehealth anywhere. Doesn't even matter what country that is in. But then also the added benefits is, let's say someone calls me, they're on vacation, they've got symptoms that are in keeping with a sinus infection. I can send medications to any pharmacy in the country. So someone's in Florida, you just give me the name and address of your local closest pharmacy, we can get that done. And then even with blood work, we can get all of that done as well, because we partner with LabCorp. So let's say someone's down in Florida, thinks they have something as basic as a urinary tract infection, and we want to do a test to make sure we're giving someone the right antibiotic. I can actually send that order by email to the patient. You can go into any LabCorp facility, which is normally associated with a Walgreens pharmacy, get that test done, and then that test comes back to me in Ohio for me to then make the decision. I did actually have a case about 3 or 4 months ago where a patient of mine who's a pilot was in Italy, ran out of his meds, so I emailed him a prescription. Can't guarantee it happened every time, but he was actually able to refill one of my prescriptions in Italy when he was traveling. So again, we're pretty well set up for the snowbirds.
I want to go back to doing direct care, with you versus being like many of us, I'm sure, have 4, 5 different doctors that have been taking care of this, that have been there for years under one doctor. So the benefit of leaving them and going to you would be very difficult, right, for that, because their care gas then might open or door or diabetes or mortality. So it would be more beneficial if someone didn't have a lot of issues, that this would be a benefit to do direct care with it, correct?
Yeah, there's kind of 2 ways to look at that. If you've got someone who's heavily under specialists and they're doing a lot of heavy specialist intervention, that could be a barrier, and that's a fair statement. The other side of the coin is, because we have time, we can manage more. So if we think about me practicing at my previous clinic versus me practicing now, I send less diabetics to endocrinology because I have the time to manage them. I always had the ability to manage them. I never had the time. That was what made us refer. So I send less diabetics to endocrinology. I had less of my cardiac patients under the cardiologist because I can monitor the echocardiograms. I can do the EKGs in my office. So although, yes, if it's very heavy interventional care that I can't do as primary care, that's a fair point. But we actually get most people away from specialists, because if I'm going to send someone to a specialist, they must be doing something that I can't do, because otherwise it's just added cost at no benefit to the patient.
So let's say, though, this person has been there, let's use the clinic for a long time, they've been there for a long time, so they, all their records are there and they're very secure in going to there. Would you refer them to somebody at the Cleveland Clinic? Yes, they respond and said, I would like to go to...
Yeah, because I'm not affiliated officially with any health system, so I can refer anywhere that myself and the patient choose fit. So we can choose who's best for that person at that time and do that referral. And when it comes to access to information, all of those lab works, imaging, all of the MyChart stuff, I can access all of that from my clinic. So it's not like they do their thing and I have no idea what they're doing. All of your blood work is still coming to me. All of your imaging is still coming to me. So we're keeping everything together. Yeah, I mean, and like saying, it is a good point. Some people, it may not be comfortable for people with lots and lots of specialists in one place, but we are also talking about the minority of the population there.
Right. I just wanted to clarify. I'm sure many of us who sit here thinking this would be awesome to do. Mm-hmm. But, you've got to approve of doctors, and that how's that going to work when you don't want to?
Well, people come, they get in, they get seen, they get time, and they soon realize the benefit of it.
Other questions? One point there, Kathy, that's important. They do have access to all the MyChart stuff for UH or the clinic. So it's not like you have to get your records or do anything.
But it's again, I think we're all uncomfortable sometimes where you're at. Is this a good move to make? Someone that's been your doctor for, let's say, 7, 8 years, do I make this move and then it's a different team? No, it's a scary thing.
And those same doctors that have been there for 7, 8 years, unfortunately, are being squeezed into that position where 7, 8 years ago they could get you in. Now the waits are longer, the visits are shorter, so they get squeezed out, unfortunately.
Question is, at the time of the summary, that essentially you're going to keep your insurance, you're going to keep your supplement insured, and that just talked about you're going to keep your insurance, keep your supplement insured, and essentially we're buying past that the care because it's so difficult for anybody to say. That's what I'm gathering the summary, but I didn't hear anyway the difference between direct patient and here is it the difference in the monthly cost.
Okay, so that concierge is completely separate. So in our clinic, we only do direct primary care. So with concierge, you pay that once a year fee to have access, and then they charge your insurance for everything they do. So you're paying both ways. With us, we have nothing to do with the insurance billing whatsoever. So with us, you're just paying that monthly membership. And then when you come to us, we're seeing you, we're treating you, we're doing everything that we can in the clinic, and we're not billing your insurance or giving you any additional charges for the services that we do. Most people do have insurance in the background to cover those catastrophic events, specialists, and if they can, imaging and pharmacy.
Not much to say.
Yeah, it is a big difference. Like I say, in Florida, concierge just gets you the primary doctor. But when you go in, they still charge you for the visit. They still charge you and send you out for labs or whatever. With this, your monthly fee kind of covers everything they can do. You still need the insurance, though, because obviously you have a hospital stay or something catastrophic. It's very, very expensive, like a surgery or something of that nature. Okay, question. Sorry, I can't. So there's one back there.
For Kathy, you speak to the difficulty of finding the snowbirds for the policy when we turn 65.
I'm sorry, I didn't.
Medicare policy for so it's a snow.
Kind of a snow protect policy when you turn to 65.
Oh, okay. Yeah. There's several different, like a supplement, you can go anywhere in the United States. But there's plenty of Medicare Advantage plans. They have nationwide networks, so they do have a network in 50 states or 49 states. And there's also PPO plans that you can go to any doctor you want to. You just pay more if you go out of network. So there are several plans made just for snowbirds.
It's not a question. I just want to make people aware that in Lake County, through the Council on Aging, we have a program called OSHIP that's part of the federal SHIP program. It's a pool of volunteers who've been trained by the Department of Insurance, and we go every year for refresher, learn the new laws, etc. No cost, and it helps people in terms of selecting the kind of Medicare plan that might be good for them. So it's very individualized. It doesn't cost a thing. Sometimes if you go to your private insurance person who handles other things, they can be restricted to a number of insurances that they particularly sell. We look at all of them, and that is a free service. They've been doing that I've been doing it for 9 years. It's probably been around 11 or 12 years. And that's available. You just call the Lake County Council on Aging. Then they start our biggest numbers that come in are usually during open enrollment. So I can say in the first week of October, call for an appointment if you're interested, and also if you just want to look at how maybe your plan isn't accommodating you this year, you might want to change to another one or change your drug plan or go switch from a supplement to an advantage, etc. They will go over everything, the pros and cons based on your individual situation.
Okay.
Can I come in?
Yep.
Okay, I agree, OSHIP is a great access, but I'm a licensed insurance agent that works with all the major health insurance plans and Medicare plans, so I do exactly that also. And then I also keep you in my records, and I send letters throughout the year, remind you of the changes. When I know you have a United Healthcare plan and I know some major changes are happening, I actually call you and tell you those changes and make sure that you read your annual notice of changes. There's no cost to use my services. But OSHIP is a great asset too.
Hi, I think question in the back. Can't see your page, but I know you're back there somewhere.
Yes, we have one right here.
Hi.
Is there an ideal patient that should do this from your standpoint? Like I'm thinking a 20-year-old who never goes to the doctor probably doesn't need to spend $80 a month to do this. Who is the person that you have thought to yourself is the ideal individual to take up this service? But I also have a question on the radiologic standpoint. So if you want to ask my next question too, or
I'll answer this one. So the ideal patient is kind of a good question, because what's ideal for a clinic, what's ideal for a doctor, what's ideal for the patient, they're all very different definitions. Our main thing is basically having some emphasis on prevention. So if you've got a 20-year-old who doesn't care about health, doesn't follow any health plans, isn't going to go and get their annual physical, things like that, well, maybe they're not the right person to be paying on a monthly basis. Maybe they should be a person that just goes to the urgent care on the intermittent times they need it. But for us, it's all about those preventative things as well. And also as well, lots of those young people have very high deductibles. They only need to avoid an emergency room once, and they've paid for 2 years of membership. And once they've paid that 2 years of membership, I'll see them as many times as they need to. It only takes a joint injection or a set of sutures for them to be out of pocket $1,000 to $2,000. So in general, it's probably people who want to prevent health problems rather than just deal with them when they pop up. And also as well, what we need to remember is we're not comparing apples to apples. Having access to a usual clinic that they can get in once a year is very different to having your doctor 24 hours when you need them, having an hour appointment when you need it, being able to get in on the same day when you need it. We get plenty of people who don't necessarily come in very much, but the texts like, oh, something's wrong with my kid, these are the symptoms, what do you think? Do I need to come in or not? It's not just about the visits and when you come in, it's about the reassurance when you need it. And you said you had a radiology question.
radiology question is, the radiology place that you refer to, are the doctors at the sites, like, could you talk to them and say, hey, can you go over this x-ray with me? Or are they in Texas and you don't know who they are, or you don't know how good they are?
We've got a combination of two places. So am I allowed to say business names? Am I allowed to say business? So I use Lumina Imaging in Mena. They're my favorite ones. They're actually under Metro. So any imaging done at Lumina is read in Cleveland on the main campus by a Metro radiologist. If you use Advantage or Network Radiology, which are both based in Beechwood, they actually have their own radiologist on site. So I can talk with any of them anytime. And also as well, if they find any significant findings that I need to know about before I go through not wait till I go through my faxes, they will actually call me to discuss that. And I've had that several times.
Question is, you have said that you take care of what you do at the clinic. And if you can't, if you need the specialist, that you will refer them out. What gets you the ability to make that appointment with the specialist any more quickly than a primary doctor? Again,
I mean, there's a couple of scenarios with that. So Can I always jump the line? Absolutely no. If you're thinking about certain specialists in this area, the wait is a long time and there's nothing I can do about that. But because I'm small and because I refer to a relatively small number of people, I can quite often pull favours. So if I needed to get someone in with a dermatologist and I believe it's something that is genuinely urgent, I can facilitate that within 48 hours, which would be quicker than a referral from elsewhere. Certain specialists I'm referring into the same pool and the same wait time as any other primary care doctor in the area. So it varies depending on who and where.
Is there a contract to sign that you would be obligated to for 12 months to renew every year? How does that work?
No, we don't do any. We don't tie people into a contract. Everything's done on a 30-day rolling basis because healthcare is different. I mean, it's not like someone's servicing your car. Kind of who cares if you don't like the person who services your car as long as they do a good job. We don't want people stuck with a doctor that they don't get on with for any reason. And we also don't want that either. So everything's just done on a 30-day rolling basis. If someone joined, they moved, had a financial change, whatever the reason was, they let us know, and that month plays out, and then they're free to move wherever they need to.
So obviously, you're seeing patients for like innocent. You yourself, being is during a day, you can see they make it baby patients. Do you have someone working with you? Other physicians that also take patients?
Yeah, so when we look at healthcare in general, there's kind of like some rules. I call it the rule of ones. So any doctor in primary care should expect to see about 1% of their patients per day. So when you're a doctor and you've got 2,500 patients, you should expect to see 25 a day. And that's when the doctors are getting burnt out. Well, because we maximize we set the maximum number at 600, we should realistically expect to see 6 per day. When we think about the hour, we have that available. Doesn't mean that we use it for everything. So for instance, for myself, if I've got a patient, let's say I'm at work tomorrow and I've got a 3 o'clock patient and I know they're quick, they're coming in for a blood pressure, I know that literally they'll probably be there 10 minutes, 15 minutes, and someone calls because they're sick, I can then kind of add on the extra time. But we always have the time available in case it's needed. And like I say, having 600, about 6 a day is what we expect. And we've not actually had a single episode where someone's needed us for a truly acute visit and they've had to wait till the next day. I mean, if someone calls us at 3 o'clock and says, oh, my ankle's hurting, it's been hurting for 3 weeks and it's not better, we might see that person the next day, but truly acute will get the same day access.
You know, that Benny talked about it constantly, but if I join with Dr. Barrett, what do I do about ER visits and urgent care?
So as I say, most people keep a background insurance. Some people have keep a high deductible, low cost plan, which would then kick in for emergency visits, specialists, hospitalizations. If people get admitted to the hospital, we're registered as their primary care. So if you did go to the emergency room, your background insurance would cover that. And then obviously I would be given all the information from the emergency room visit. And then we would plan to basically do a follow-up, post-discharge follow-up to cover everything that's been going on.
Let's go with this acting. But going back to the radiology and test through it, you have your favorite places that you go to. My supplement is specific to clinic. She's worked with them but they don't need a place to be. They go like you ain't here else to go.
Yeah, I mean, that's completely flexible by the person. I mean, if you came to me and were like, I need a GI doctor for a colonoscopy, who do you recommend? I know in my mind who I would recommend. If you say, I need a GI doctor in Cleveland Clinic, I would be able to refer to Cleveland Clinic. So it's completely individualized. Or if you had a relationship with a previous specialist that you were happy with, I can refer. And I'm not restricted by any of the networks or systems here. I mean, even if someone was in, let's say someone went to Florida for the winter. If your colonoscopy is due in Florida and you tell me a GI doctor in Florida where you are, I can send a referral there. So it's completely flexible. I mean, I do have my ones that I preferentially would recommend, but it still remains completely flexible.
So do I have to renew my membership every year if I choose to stay with you?
No, everything 30-day rolling contract until you chose to stop. So
let's say I want to stay with you.
Yep, it just rolls and rolls and rolls. Yeah.
Okay, so I have to worry about that. You have 600 people.
No, everyone in now is already part of the 600. When I hit 600, I stopped taking new patients. If someone decided they were going to leave for whatever reason, I can then replace them with a new person, but I'll never go over 600.
But most direct primary care practices, we're not talking specifically direct primary care is all over the country. Generally what will happen is when either the doctor or the PA hits whatever their number is, that they bring in another physician or PA. Because the business is still growing and it is a business. So as they grow, they'll just add more people to the practice.
I can vouch for Dr. Barry. He's an amazing doctor. I started happy with him. He didn't pay for that.
Other questions? Any other questions?
How many physicians are in your practice? It's just yourself?
No, there's myself and Courtney, who's a physician's assistant. We're going to be adding a third person in March. So, we've grown quicker than we expected.
Okay.
So it'd be 600 per person?
Per person, yeah.
So how many do that?
Me personally, I think about 510 at the moment.
Oh, so what do I need to do to sign up?
You go on the website, hit enroll now, fill it in, and then you're in.
Any other thoughts?
One of the things, as I say, whether it's medical or it's any other type of question, feel free to reach out to us. Certainly if it's not something we provide directly, your advisor has access to people with everything. Tonight we had a client, actually, their husband, they're on a cruise, he got very sick. They hospitalized him. They're stuck like in the middle of the country, and we just chartered a flight for them to get him back. So we can, any of the advisors in our office have capability, whether it's something, easy like a CPA or an attorney, or it's something tougher like a nanny or anything else. We can certainly help with that. So with that, we appreciate you joining us. We have 3 upcoming events. The next event we're doing is an election update on October 23rd. It's going to be up at 4 Points. If you have not signed up and you're interested, the guest speaker is a gentleman named Peter Lefkin. He's been in Washington forever. He'll be talking about all 3 races, the House, the Senate, the presidential race. January 18th is something really special. We have really a legendary economist, Jeremy Siegel, is going to be here. That'll be at Mentor High School. And he'll be talking about kind of the outlook ahead. He's written a bunch of books, one very famous book that's been out for quite a while. He was head of economics at Wharton. You've probably seen him on CNBC or CNN. And then the end of January, we have our next trip, which is a 6-day all-inclusive to Jamaica. So if you want to get out of the cold, that's going to be fun. As I say, we've, done this. December will be our 35th year that we've been here in Lake County. So we've done it a long time, and we appreciate, everybody's support, and plan on doing it for at least another 35 years, as far as that goes. So we appreciate you guys coming out. And if you do think of any questions, just reach out to your advisor, and we can certainly direct you the right way. Thank you.